Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. Today's topic is HIV and opportunistic infections, skin and mucous membranes. We have with us today Dr. A.K. Puri sir from NACO and Dr. Satyendra Kumar Singh sir from IMS PHU. We welcome you both for today's session. I now request Puri sir for opening remarks.
Thank you. And I welcome all the participants. Special thanks to Dr. Satyendra Singh, Satyendra Kumar Singh from BHU for joining us. This is an important session. As you know that the cutaneous infections are very common amongst the PLHIV, and you have to, whenever you are seeing the patients, you will come across these uh, infections very often. So you have to day in and day out. These are very important, and you have to learn it very nicely. And uh, these are the same infection which are there in our. I mean, we are also having, but in this case, the uh, and the frequency will be comparatively more, and the the illness will be higher on the higher side, and you have to take care of that, and you have to deal with that every day. So these problems are staphylococcal, streptococcal infections, bacillary angiomatosis, mycobacterial disease, syphilis, and also we will be learning about the fungal infection, systemic deep mycosis, viral infection, herpes simplex, herpes zoster, mollusca contagiosum, human papilloma virus, oral hairy leukoplakia, and cutaneous malignancy amongst the PLHIV. We will also go through the drug reactions and the various drug reactions are also have, and the pruritic uh, diseases which are effective, which could be that may you will be coming across, you are coming across that also whenever you are reading. So welcome once again to all the ART centers, all the participants from ART center and my NACO team, and Dr. Satyendra Kumar Singh. Over to over now, over from my side. Thank you.
Thank you, sir. Uh, Dr. Singh, sir, we'll just quickly run through the pre-test and then I'll hand over the session to you, if that's okay.
Okay, okay, ma'am.
Thank you, sir. Kiran, sir, can we have the pre-test, please? The pre-test is now visible on your screen. Participants are requested to please attempt the pre-test. There are 4 questions in all. Please scroll through the questions and answer all the 4 questions. Kindly note the pre and the post-test are linked to your attendance. So please be with us right up till the post-test. Participants are requested to please attempt the e-poll, the pre-test questions, please. Kiran sir, we can end the e-poll now. Thank you to all the participants for attempting the pre-test. Please type your questions in the chat box. All the questions shall be taken at the end of the session. I now request Dr. Singh sir to please continue the session.
Good afternoon, everyone. In this session, we will discuss different opportunistic infections and some inflammatory conditions and cutaneous malignancy. These are the different sections, which include the skin manifestation of the bacterial diseases, fungal diseases, viral diseases, some inflammatory condition, cutaneous malignancy, and the miscellaneous questions. Next. More than 90% of the patients living with HIV and AIDS may develop skin or mucous membrane lesions. And about 36 to 52% patient of the child living with HIV AIDS may develop the skin manifestation in their course of the disease. Identification of certain skin condition can predict the presence of HIV because there are some conditions like oral hairy leukoplakia or exanthema or eosinophilic folliculitis, which are very characteristic of the HIV AIDS. Persistent, most of the dermatological conditions are commonly found in our OPD, but if any dermatological condition persists for more than the usual courses, are recurring, are chronic, are very severe, are resistant to treatment, are having some atypical presentations, so one should suspect HIV infections. Next slide, please. These are the spectrum dermatological manifestation in patients living with HIV/AIDS in relation with the CD4 cell count. In clinical practice, we can guess the CD4 cell count on the basis of the dermatological manifestation. In this chart, you can see that when the CD4 cell count falls below 500 cells per microliter, then most of the dermatological condition come into the pictures. Earliest manifestation of the mucocutaneous manifestation is the seborrheic dermatitis, which is very common dermatological condition. But in the case of HIV/AIDS, severity will be more and it will be more chronic. So you can see here, when the CD4 cell count falls below 500 and up to 200, then patient will have bacterial infections, viral infections, wart, and the herpes zoster. These are the conditions. But there are some other conditions, mucocutaneous condition, which are mainly found when the CD4 cell counts falls below 200, like papular pruritic eruption of HIV/AIDS, oral hairy leukoplakia, Kaposi sarcoma, and the most importantly, the chronic herpetic ulcers. These are the some conditions which are found when the CD4 cell counts falls below 200 cells per microliter. Next. Skin diseases are classified into 4 groups. The most common conditions are the infective condition, which includes the bacterial infections, viral infection, fungal, and sometimes parasitic infections. Inflammatory conditions like psoriasis, ichthyosis, dryness, and reactive arthritis, cutaneous malignancy, and among these, the Kaposi sarcoma and non-Hodgkin's lymphoma are the important to know. And there are some miscellaneous conditions which will be discussed in detail later on. Next. Bacterial, these are the name of the clinical diagnosis of the bacterial conditions. Most of the bacterial conditions are commonly found in our OPD, except 2. One is bacillary angiomatosis, which is not found generally in our OPD. It is found mainly in HIV positive patients or immunocompromised patients. And the last one, which is the disease caused by atypical mycobacteria. So this condition is also not found in general dermatological OPD. And on all other bacterial infections are very, very common in our OPD. But there are certain differences. There may be certain differences like in the severity and the recurrence, which we'll discuss in the later on. Among fungal infections, most common fungal infections found in the HIV/AIDS are the candidiasis. Candidiasis is very common in HIV positive patients. And genital candidiasis, cutaneous candidiasis, oral candidiasis, sometimes oral candidiasis with the esophageal candidiasis. These are the most common fungal infection found in HIV/AIDS. Dermatophytosis is very common dermatological condition nowadays. We are facing the epidemic of the dermatophytosis. Of course, this will be also found in the HIV positive patients. And these are the last three: penicillosis, Cryptococcus, and histoplasmosis is not commonly found in the general non-HIV cases. So these are the very characteristic of the fungal deep mycosis found in the HIV/AIDS cases. We will discuss one by one. Next. These are the viral infections. Among these, oral hairy leukoplakia is very characteristic to HIV/AIDS, which is generally not found. We are not seeing this condition in our OPD. Herpes zoster, herpes simplex, blossom contagiosum, condyloma acuminata, which is also known as wart, Verruca vulgaris, Verruca plana. These are the common dermatological conditions. But in HIV cases, the severity will be more, and of course, the duration of the disease will be more. So these are some common conditions found in the HIV/AIDS. In arthropod, scabies. Scabies is a very common dermatological condition. In HIV/AIDS, a special form of the scabies found that is known as the crusty scabies or Norwegian scabies, in which the severity will be very high. We will discuss later on. Leishmaniasis may be found. Demodex folliculitis is also very common in HIV positive patients. Next. These are the inflammatory conditions which is found in patient living with HIV/AIDS. Among these, cirrhosis and ichthyosis. I think cirrhosis and ichthyosis is found in almost all cases of the cases which are referred from the RT center to our OPD. The cirrhosis and ichthyosis is very, very common in HIV positive patients. Psoriasis is very common dermatological condition. It is very common, especially in the winter season. But in cases of the HIV, severity of the psoriasis should be more. Patient may present with the generalized involvement. Patient may be present with the ectodermic psoriasis or generalized pustular psoriasis. So if there is more severe form of psoriasis, one should suspect of HIV infection. Seborrheic dermatitis, again, it is very common dermatological condition which involves mainly the scalp, face, nasolabial folds, periauricular area, chest. And this may be the first, we considered it as the first dermatological manifestation in HIV/AIDS patient, because these conditions occur even when the CD4 cell count is more than 500. Rhesus disease, which is now known as the reactive arthritis, is may be found within the severe form of that condition. Eosinophilic folliculitis. This is very characteristic to HIV/AIDS. This is very uncommon even in our setup. But if patient is having eosinophilic folliculitis, most probably patient is suffering with the HIV/AIDS. In eosinophilic folliculitis, patient will have severe itching, and the most of the lesions will be found on the upper part of the body, above the nipple line. This is very characteristic distributions. The patient will have the very severe pruritus, itching, and may develop the scoriated papules, nodule, which may be get infected. Infection is very common. So this is the very characteristic of the HIV/AIDS. Atopic dermatitis. Atopic dermatitis severity will be very high in HIV case. Next. Cutaneous malignancy. Among these two are the very notorious: Kaposi sarcoma, non-Hodgkin's lymphoma. In our setup, Kaposi sarcoma is very, very rare. If patient is having Kaposi sarcoma in our country, then most probably patient is because of HIV/AIDS. So Kaposi sarcoma is very characteristic for the HIV/AIDS. Most common malignancy found in our Indian patients are the non-Hodgkin's lymphoma. We'll discuss non-Hodgkin's lymphoma later on. Other cutaneous condition is the acute senoconversion illness. This occurs in the first infection after getting infection, 2 to 4 weeks after the getting infection, and patient will develop the rash. We'll discuss in detail. Drug reactions are very, very common. Incidence of drug reactions are just double in comparison to non-HIV patients. And in majority of cases, patient will have the severe type of drug reactions like Stevens-Johnson syndrome, drug-induced hypersensitivity syndrome, and the toxic vitamin glycolysis. The chances of drug reactions will become the double, and the severity of most severe type of drug reactions occur in cases of HIV/AIDS. Puritic papular eruption, these are the very common. I think in our OPD, which get the patient from the RT center, puritic papular eruption is very most common dermatological conditions found. And most of the time, the CD4 cell count is less than 200. So because this is mainly precipitated by the mosquito bites, so we will discuss this patient and this condition later on. Next. Skin manifestation of Staphylococcus aureus and streptococcal infections. Staph aureus is the most common opportunistic bacterial infection found in the HIV positive patients. About 90% of the opportunistic bacterial infections are caused by the Staph aureus, and the remaining 10% most commonly the Pseudomonas aeruginosa, and sometimes streptococcal infections. That is the Staph aureus, which is the most common opportunistic bacterial infection found in the HIV patient. We'll discuss the different condition which is caused by Staph aureus bacteria. Next. These are the different conditions which are mainly caused by Staphylococcus aureus. All these three conditions are generally found in non-HIV cases also, but the incidence will be more in HIV positive patients. You can see here in the pubic area, you can see the many papules, implement papules, and some pustules, although they're not clear in this picture. And the third, non-bullous impetigo. This is a very common condition in the children, in which you can see the honey-colored crusting lesions found around the mouth. This is a very common findings in the children, which is mainly caused by the Staph aureus. In center of the lesion, this is found the deep bacterial. In this case, Staph aureus and sometimes Streptococcus may be responsible for this, and Ecthyma Pseudomonas aeruginosa must be suspected, because Pseudomonas aeruginosa is also very commonly about 10% of the cases it may be found in Ecthyma. So this is the deep bacterial infection. Next. Skin manifestation of Staphylococcus aureus. Among the bullous impetigo is very superficial, just like folliculitis. Bullous impetigo is very common in pediatric age group. Impetigo may present with the bullous lesion, sometimes bullous lesion, but majority of the times it is the crusted form. Crusted form is more common than the bullous form. It mainly presents as a superficial blister erosions that may be polycyclic. It mainly found on the face, sometimes on the trunk and the arms, but the most common sites is the face. And treatment is by topical antibiotic and the systemic antibiotic, because sometimes in bullous impetigo it is caused by streptococcal infections, which may lead to, in some patients, may lead to the kidney problem, glomerulonephritis, streptococcal glomerulonephritis. So it is better to start with the systemic antibiotic. And the cephalosporin, aminopenicillin, these are the very effective in our cases. Erythromycin, we don't use erythromycin because the resistance is very common with the erythromycin. So commonly we give cephalosporin. Still, cephalosporin are very effective in treating impetigo. Next. Skin abscess are pyomyositis. Pyomyositis especially is generally we don't see pyomyositis cases unless patient is immunocompromised, diabetic, or HIV positive. If there is a pyomyositis, one should suspect of immunosuppression. Skin abscess, sometimes we see skin abscess in non-HIV cases, but if there is a skin abscess or pyomyositis, one should think about the immunosuppression. In this skin abscess, follicular lesions extend more deeply and forming abscesses and making the affected area fluctuant and warm. And in pyomyositis, there is blood collection in the muscles, which are not common. Sometimes we may found, we can see the one case per 6 months to 1 year. The pyomycete is not so much common even in the HIV positive patient. If the in both the conditions, we have to drain the lesions and withdraw the pus and start antibiotic at least for 10 to 14 days. Cephalosporin is very commonly used. Cephalosporin, the clotrexazole, orally or sometimes cloxacillin 1 to 2 gram IV 6 hourly can be. And if required, depending on the culture sensitivity report, vancomycin may be used. Next, furunculosis or folliculitis. Folliculitis is very common, but in HIV positive patient, we have seen generalized folliculitis. In general, in non-HIV cases, folliculitis are very localized. But in HIV/AIDS patients, we see the generalized form of folliculitis, almost involvement of almost more than 80% of the body surface area. And furunculosis is nothing but the severe form, deeper and severe form of the folliculitis. In this case also, we have to give topical antibiotic as well as systemic antibiotic. Next. Bacillary angiomatosis. This is the conditions which is not found in it is very rare in non-HIV cases. But bacillary angiomatosis is very commonly may be found in the HIV positive patient. It is caused by mainly two bacteria, Bartonella hanselii and Bartonella quintana. It is basically transmitted by the cat scratch and body lice. Some fleas also can transmit. This is the name suggests, angiomatosis means there will be the benign neoplasia, and the most of the time lesions will look like purple to red. So lesions start with a small purplish red papule, which may later on convert into the nodular form peduncular lesions, and we can see their vascular appearance because the lesions will look like reddish and purple. It means there is the benign neoplasia of the blood vessels. Sometimes bacillary angiomatosis may involve our internal organs like the liver and spleen, bone marrow, bone may be involved with bacillary angiomatosis. If the systemic involvement is there, bacillary involvement is there, then patient may have the fever, night sweats, weight loss, and anemia with bacillary angiomatosis. Diagnosis is by special stain, liver impregnation, or by the electron microscopy. And the treatment, it is very sensitive to macrolide. So it been in this condition, erythromycin 500 mg 4 times a day or doxycycline 100 mg BD can be given. But if there is contraindications are not effective, then erythromycin 500 mg daily can be used. But the treatment should be given for at least 3 months. And in this condition, response usually occurs after 3 to 4 weeks. So don't expect response within a week, 1 or 2 weeks. Response occur only after 3 to 4 weeks. If there is no response after 4 to 6 weeks, then we can change the antibiotic and look for the another antibiotics for the management of these conditions. Next. Mycobacterial diseases. This skin manifestation of the mycobacterial diseases, we can see in this first, we can see the lesions in the 2 ulcers in the axillary area. You can see the enlarged lymph nodes. This is called, we call it as the scrophloderma. First, there is an involvement of the lymph nodes, which gets separated and later on burst out and involve the skin. So we can see the very characteristic margin of the skin is undermined margin. This is the very classical of the tubercular involvement. So this is the scrophloderma. You can see the involvement of the neck lymph nodes, which get separated, and then you can see the pus discharge from this. So this is the condition which is very common, skin tuberculosis. Next. These are the different form of the skin tuberculosis. Most common is the lupus vulgaris, scleroderma, tuberculosis verrucosa cutis, which are found in our setup. Tuberculosis verrucosa cutis are mainly found on the extremities and in hands and feet. These are the most common site. Scleroderma common sites are the lymph node area, neck area, and the armpit area, and the groins. Lupus vulgaris can occur on the hands, feet, buttock, face. These are the common sites for the lupus vulgaris. Mycobacterium intracellular commonly presents as the chronic sinuses involve the lymph node, which can develop the scrofula, chronic ulceration, etc. Mycobacterium haemophilum rarely can present with the cutaneous surface ulceration, adenocarditis, or the arthritis. Next. Treatment is ATT. Syphilis. Syphilis is the one of the still very common STI which we see generally in our STD clinic. In most of the time, presentations are same as non-HIV patients. We see primary, so there are different stages of the syphilis: primary syphilis, secondary syphilis, latent syphilis, and tertiary syphilis. In primary syphilis, in most of the time, there will be a single painless indurated genital ulcers, which is known as the Sankar. So indurated genital ulcers mainly found on the male genitalia. This induration may be absent on the female genitalia or extragenital sites. So induration is characteristic of male genital region. So if there is any painless ulcer with induration, do suspect primary syphilis, along with inguinal lymphadenopathy after 1 to 2 weeks of the Sankar. And this primary syphilis stage persists for 3 to 6 weeks. After that, patient will develop the secondary syphilis. This is the stage of the syphilis in which we see the most of the patients. The most of the patients come in this stage in our OPD, secondary syphilis. And the most common presentation of secondary syphilis is the asymptomatic, non-pruritic, hyperpigmented, scaly macules on the palms and soles. So palms and soles are the most commonly involved parts of the rise in the secondary syphilis. And this secondary syphilis stage again resolves in 3 to 6 weeks. Generally, we don't see primary syphilis Sankar with the secondary syphilis in non-HIV cases. But in HIV cases, we can see both these stages simultaneously. We have seen many cases of primary syphilis and secondary syphilis in HIV positive patients, which is very uncommon in non-HIV cases. Treatment is still benzathine penicillin G, 2.4 million units, IM single dose. Still penicillin is the treatment of choice, and there is no report of any resistance with the benzathine penicillin in respect to the syphilis. So for the syphilis, primary, secondary syphilis, single injection of the benzathine penicillin 2.4 million units is sufficient, and this should be given after performing the hypersensitivity test. And after giving this benzathine penicillin, follow-up of RPR, rapid plasma reagent test, must be done at 6 months until it titer become the negative. Next. We can see here the primary syphilis. There is one single well-defined genital ulcer on the side of the penis, and the border is slightly elevated. Look, if you feel with the gloved finger, then it will feel like a button-like hard. In syphilis, we'll find the firm, hard, button-like hard ulcer on the male genitalia, which is, this will be painful, but in generally painful, but in HIV positive patient, this ulcer may be painful due to secondary infection with the Staph aureus. If there is, generally there will be no pain in the genital ulcer, but in HIV positive, this ulcer may be painful. But induration will be there. The induration is very characteristic, finding in the primary Sankar. You can see here the hyperpigmented, non-itchy macules on the bilateral symmetrical distribution of the palms and soles. This is the most common presentation of syphilis in our OPD. You can see here the multiple, although it is not clear, but if you see carefully with the help of lens, then you will find the fine scaling will be there, and that these lesions will be non-pruritic. So this is the most common presentation of the secondary syphilis. Next. After finishing bacterial infections, we'll come to the fungal infections. Next. Candidiasis. Among the fungal infection, most common opportunistic infection in our country is tuberculosis, while the candidiasis is the most common opportunistic infection in the developed country. And candidiasis in our country, candidiasis is the second most common opportunistic infections in HIV positive patients. And the candidiasis, mainly most common site of candidiasis is oral mucosa and genital mucosa, both. In oral candidiasis, a white membrane covers the tongue that reveals the surface of the. There are different type of oral candidiasis. Most common is pseudomembranous type, in which there is a slight surface, which if you remove the surface, we will see the raw surface area. There are other types of oral candidiasis like hyperplastic candidiasis, angular candidiasis, atrophic candidiasis, but most common is the membranous candidiasis, which is easily removed. Sometimes oral candidiasis may be associated with the esophageal candidiasis. So if patient is having oral candidiasis, patient may have, along with oral candidiasis, may have the esophageal candidiasis. If patient is complaining of difficulty in swallowing, a pain during the deglutition, so always can suspect about the esophageal candidiasis. Candidiasis may involve the flexor part of the body, like the axilla or groin, and sometimes it may involve the nails, tissue around the fingernails, and which presents as the paronychia. Diagnosis is by potassium hydroxide examination of the scales taken from the border or a satellite pustule. The diagnosis is very can be confirmed by the KOH examination. And under microscope, you can see the yeast-like structure and the pseudohyphae. Pseudohyphae is a diagnostic of candidiasis. Treatment, topical and fungal, if very mild, there is a mild involvement, topical and fungal may be enough, such as clotrimazole or ketoconazole cream and fluconazole 100 milligram, or if pediatric age group 3 to 6 milligram per kg per day, in children usually once for 10 days. This is for the oral candidiasis. But if along with the oral candidiasis, patient complaining of difficulty in the swelling or the pain, the patient may have the esophageal candidiasis. In that case, dose of fluconazole should be 200 milligram per day for 14 days, at least for 2 weeks. Next, tinea infection. Tinea infections are nowadays become very, very common, and we are facing the epidemic of tinea infections. So even in the non-HIV cases also, tinea infections are very, very common. Nowadays in rainy seasons, it is become very common and very extensive. It is mainly some, in non-HIV cases, it is mainly localized with the groin area, yeah, axilla, or the area where there is more perspiration, more sweating. But in HIV positive patient, there may be generalized involvement. Sometimes whole body involvement may be there. So tinea infection is very, very common in general as well as, but if there is very severe involvement, not responding to general treatment, they are very persistent, then do suspect HIV infections. If it involves the groin, we call it tinea cruris, body involvement, corporis, hand involvement, depending on the anatomical sites we name. Or if it involves the nails, we call it as the onychomycosis. In child living with HIV, tinea capitis can present with the broken air. Tinea capitis is common in the children. In general, tinea capitis does not occur in the adult patients, because after puberty, we don't see tinea capitis. But some patients we have seen tinea capitis when the adult, and one of them patient was the case of HIV. So tinea capitis is not found after puberty. This is the rule. But tinea capitis is very common in children living with HIV/AIDS. And sometimes broken hair, non-scarring alopecia, scaling and pustules, these are the most common presentation. But sometimes in tinea capitis, patient will present with the scarring alopecia also, boggy swelling, which is known as the carry-on, a very inflammatory condition, boggy, studded with multiple pustules. So there are many other presentations besides this non-scarring type of alopecia. And if you see the tinea infection, it is better to refer to the dermatologist. Next. Other fungal infection, Pitosporum ovale orbiculare, which is known as the, previously we call it the Pitosporum ovale and orbiculare, and nowadays these are called the Malassezia furfur. And this very superficial fungal can cause responsible for the pityriasis fascicular, seborrheic dermatitis, and sometimes pitosporal folliculitis. The most common site is the scalp, flexor, and upper part of the tongue. Diagnosis is clinical, but it can be confirmed. If you want to confirm, you can confirm by the QS examination of the skin scraping. Treatment is very simple. We can either patient, if patient in non-HIV cases, then selenium sulfide shampoo may be sufficient. But if patient is HIV positive, along with the shampoo, one should also use the topical imidazole cream, and sometimes oral antifungal agent may be used, like the oral teconazole, 200 milligram daily for 1 week. Next, systemic and deep mycosis. Generally, systemic and deep mycosis is not found in the non-HIV cases. It is not so common. But if patient is immunocompromised, you are having HIV infection, then these infections becomes common. These include the penicillosis, which is nowadays we call it a tularomycosis, caused by the Tularomyces marfanii. And these conditions mainly found in Northeast India. This is not found in other part, very rare to other parts of the body. The most common region is Northeast, our Northeast states. Cryptococcosis, again, Cryptococcus neoformans is most commonly Cryptococcosis is found involve the central nervous system. Cryptococcal meningitis is more common than the cutaneous involvement. Cryptococcosis, most of the times skin lesions are found with cryptococcal meningitis or after cryptococcal meningitis. But in some cases, it may precede the CNS involvement. But majority of times, it is associated with the cryptococcal meningitis. And next is the histoplasmosis, sporotrichosis, aspergillosis, candidiasis we have already discussed, but sometimes there may be systemic involvement with the candidiasis, coccidioidomycosis, and actinomycosis. Actinomycosis, we also call it the mother of heat, a mycetoma. Tularomycosis is nothing but the penicillosis. The name of penicillosis has been changed. It is caused by the Tularomyces marfanii, a fungus. Central, in this condition, we found the central necrotic papular nodule with an umbilication, just like the molluscum contagiosum, on the face, trunk, and extremities, occurring in 40 to 70% of the patients. In cryptococcal skin lesions, again, the umbilicated skin lesion may be found, asymptomatic umbilicated lesions on the face and the other part of the body. Next, we can see here some photograph of the deep mycosis. We can see tularomycosis. Of course, you can see the Manipur, Imphal, our northeast state, which don't see in our if we don't see this type of the condition. I think you have seen only 1 or 2 cases of penicillosis. You can see here the large nodules with central ulceration, molluscum conditional lesion. There is one lesion here, another lesion developing here. So these are the lesions of the penicillosis or tularomycosis. You can see here the cryptococcal lesion. Most probably this patient is also having the cryptococcal meningitis. You can see the general condition of the patient's facial condition. Again, you can see the molluscum contagiosum like lesions. If you see carefully with the help of the hand lens, you can see the umbilical. There will be some slight depression in the center, just like the molluscum contagiosum. This is the histopathology. Again, patient will have umbilical lesions, involvement of the trunk also. Next, after fungal infections, viral infections. So in next slides, we'll see the viral infections. Majority of the viral infections are found at the same as in the non-HIV cases, except Kaposi sarcoma associated virus, which is not common, and the oral hairy leukoplakia. These two conditions are uncommon or rare in non-HIV patient. We'll discuss on them. Next slide, please. Among the viral, human herpes virus 8, which causes the Kaposi sarcoma. Kaposi sarcoma is rare in India. So it is very, very uncommon. If anyone is having the Kaposi sarcoma, that patient is definitely will be a case of HIV disease. Kaposi sarcoma, there are different types of the Kaposi sarcoma, like classical Main first Kaposi disease was described by Kaposi was classical involvement, which is found around the Mediterranean Sea. Endemic form, which is found in the East African country and among the transplant-related patient, and AIDS-related as well as rare neoplastic disorders like primary effusion lymphoma. The Kaposi sarcoma, acidovirus causes Kaposi sarcoma and primary effusion lymphoma, and sometimes solid organ variants, and the lymphoproliferative disorders like the multicentric Castleman disease. So this virus can cause some other condition also besides Kaposi sarcoma. And the most common site is the face and the oral mucosa. Skin lesions, most common site of skin lesions are on the face, especially the tip of the nose, on other parts of the face. First, the skin lesions start with the non-tender, hyperpigmented violaceous macules or nodules on the skin lesions. Initial lesion of the sarcoma looks like the mosquito bite or bruise-like, mild bruise-like and mosquito lesion, or mosquito bite-like lesions. Oral lesions, purplish fleshy swelling on the roof of the mouth is very common. Sometimes there will be involvement of the lymph node. Kaposi sarcoma may involve the GIT also. The second most common, GIT and the lungs also. Kaposi sarcoma may involve the skin, lymph node, GIT, and lungs also. Next. We have already discussed this. If it involves the lung, a presentation will be similar to the pulmonary tuberculosis or pneumocystis carniae pneumonia. The presentation of pulmonary Kaposi sarcoma and pulmonary tuberculosis and PCP is very similar. Diagnosis is by cytologic and immunologic cell markers as well as histopathology. Next slide, please. These are some clinical photographs of the Kaposi sarcoma. You can see here, these are the lesions, purplish lesions involving the lower eyelid. You can see that can also involve the lower legs, but lower leg involvement is found mainly in the endemic form of Kaposi sarcoma, which are found in some Eastern African country. This is the very uncommon site for the in HIV-related epidemic Kaposi sarcoma. Lower limbs is mainly found in the endemic form. In HIV, we call it a epidemic Kaposi sarcoma. In epidemic Kaposi sarcoma, face is the most common site, face, nose, and the other part of the face, and the palate. Palate is also very common site for the Kaposi sarcoma. You can see here the purplish lesions because the Kaposi sarcoma is not a true sarcoma. It is basically the benign neoplasm. It is not a true sarcoma. Multicentric vascular neoplasm. We can't say the benign, but it is not a true sarcoma. It is a false sarcoma. You can see the purplish color is due to the neoplasia of the blood vessels. Next slide, please. Management of Kaposi sarcoma depends upon the number, site, and the involvement of the visceral organs. Face is the very common sites in the HIV positive patient. So if there is a lesion on the face which produces the causing the cosmetic disfigurement, that treatment should be. Sometimes the lesions may resolve with the ART. So if there are very few lesions, not there is no involvement of the visceral organs, no lesions around the joint, because the lesions around the joints are really very painful. So if there is no lesions around the joints, no visceral involvement, and not causing the cosmetic disfigurement, it is better to leave the lesions because it may resolve with the ART. The Kaposi sarcoma lesions are very sensitive to chemotherapy and the radiotherapy. So it is very sensitive. If you can see here, if there is advanced Kaposi sarcoma, visceral involvement, then we can use the chemotherapy with ART, with the liposomal doxorubicin. Avoid use of corticosteroids in patient Kaposi sarcoma, which is very obvious, it should not be given. And these are the treatment. Primary effusion, if it causes the primary effusion lymphoma, in that case chemotherapy should be used in consultation with the specialist plus ART, or oral valganciclovir or injectable ganciclovir can be used as a adjunctive therapy. Next slide, please. Herpes simplex virus disease. Mainly the herpes simplex, human herpes virus 1 and 2 are the very, very common. The very common infection, even in the non-HIV condition. HIV, HSV1 mainly causes orolabial herpes, oral herpes. HSV2 causes genital herpes. The HSV in HSV1, most of the time lesions resolve without treatment in 1 to 2 weeks, while HSV2 lesions resolve in 2 to 3 weeks. But if patient HIV positive and CD4 cell count is low, the lesions may persist for more than 1 month. So if any lesion of herpes simplex virus, a herpetic ulcer, persists for more than 1 month, we label them as a chronic herpetic ulcer. And the most probably the CD4 cell count will be around 50, definitely less than 200, and it is the stage 4 of the HIV infection. If there is a chronic herpetic ulcer, most probably patient is case of HIV. At our center, if we didn't see any chronic herpetic ulcer without HIV infection. So if there is a chronic herpetic ulcer which persisted for more than 1 month, patient is case of HIV infection. It is very common. You can see here the more than 95% of the homosexual men with the AIDS have a history of HSV infection. HSV infection recurrence is the rule in both of the disease. If someone has got the HSV1 infection, HSV2 infection, the infection has to be there for lifelong, and patient will develop the lesions often, you can say usually most commonly 4 to 5 times a year. So recurrence is the rule. Patient will have recurrent type of the skin lesions in HSV1, HSV2 infection. HSV viral shedding occurs more frequently when CD4 cell count falls below 300 cells per cubic millimeter. In general, also in non-HIV cases also, there will be viral shedding. But if patient is HIV positive and CD4 cell count is less, then viral shedding will be more frequent and the more in large number. Significant cause of proctitis in men with HIV infection who have sex with men is most probably due to herpes simplex infection. The manifestation of non-mucosal HSV infection like HSV keratitis, HSV encephalitis, HSV hepatitis. So herpes simplex may involve the eye, it may involve the CNS, it may involve the skin and soft tissue, or like those observed in HIV seronegative, because these conditions may be found in the non-HIV cases also. Next. There are different phases of the herpes virus infection. Primary infection means first time. If the host acquired infection the first time infection will be most severe type of infections. Severity will be very high because recurrence is the rule. After the getting primary infection, even without treatment, the lesion will resolve by itself within 1 to 2 weeks, or 2 to 3 in the case of genital herpes, and patient will go into the latent infections. The there will be viral, patient will be infected, patient can transmit the condition HSV2 without having any skin lesions, any skin and mucous membrane lesion. And reactivation is very, very common when there is the host immune system is impaired or any change in the host immune system, there will be reactivation of the HSV1, HSV2 infections. Next. These are the clinical manifestations. Most common clinical manifestation in orolabial herpes, most common site is involvement of the lips and the oral mucosa. This is the very common infections. I think this is very common viral infection among our general population also, which is mainly transmitted by the kissing. Most of us get this infection in our childhood time due to love by our near and dear ones. So orolabial herpes, patient most lesions start with the vesicles which get ulcerated. So most of the time we see the superficial ulcerations on the lips area, which is very common presentation. And in genital herpes also, most common presentation is the multiple painful superficial ulcers. But initially, patient will have vesicle formation, clear fluid filled lesion, small clear fluid lesion is very, very common. So lesions usually started with the vesicles, which later on get ulcerated and the crusting. The oral labial disease usually resolves within 1 to 2 weeks. You can see here the course of illness in untreated patient is 5 to 10 days. In genital herpes, the lesions resolve in 2 to 3 weeks. So in both the condition, recurrence is the rule. So this condition will recur and sometimes, most commonly 3 to 5 times, 3 to 5 episodes per year. In HIV cases, recurrence may be more. But this is the in untreated patient. But if patient in HIV positive patient, this course may be prolonged, sometimes more than 1 month also, if CD4 cell count is less than 200. Next slide, please. You can see at this is the, I think this is the primary infection. In primary infection of the herpes labialis, severity will be highest in the primary infection. You can see at the vesicular grooved vesicles here. We can see the grooved vesicles, and which later on converted into the pustules. And after 1 to 2 days, the vesicle will get ruptured and patient will develop multiple ulcerations, which later on after 3 to 4 days will get crusted and resolve in 7 to 14 days. This is the genital herpes. You can see here, it is very uncommon to see this type of lesions in our clinical practice, because this vascular lesions will be ruptured within 2 to 3 days, and most of the time we see the multiple superficial erosions. But in HIV cases, these superficial erosions converted into the deep ulceration, deep and large ulcerations. So these are the clinical picture photograph of the oral and the genital herpes. Next slide. Diagnosis of herpes simplex virus is very simple and clinical. Most of the time, there is no need of going for PCR and viral culture, because this facility is not available even at our institute also. So I don't think, very rarely this test needed. Most of the time we diagnose. But if patient is having chronic herpetic ulcer, then it will become problem for some peoples. But in majority of cases, we diagnose herpes simplex virus disease on the basis of the history and clinical picture. Patient will give history of recurrent involvement, same type of lesions in many times. So recurrence and superficial painful erosions, ulceration are characteristic of herpes simplex virus disease. Management. Generally, in orolabial lesions, if patient is non-HIV, treatment should be started within hours, but not after 24 hours, because the active multiplication of virus occurs within 24 hours. So after 24 hours of orolabial lesions, we don't give antiviral treatment in non-HIV patients. But if patient is HIV positive, then we have to give antiviral treatment even after 1 week or even after 2 weeks of involvement of the orolabial lesions. And the acyclovir duration of the treatment is usually 5 to 10 days. Acyclovir is given 400 milligram 3 times a day, and in children 20 milligram per kg body weight up to a maximum of 400 milligram QID for 7 to 10 days. Or valacyclovir can be given 1 gram orally twice a day. So this is the management. Management is very simple. Management of genital lesions is almost same, but sometimes you have to give slightly. Initial genital lesions treatment is given for 7 to 10 days. Recurrent genital ulcer duration treatment will be 5 to 10 days. Again, is treatment dosing is the same. Dosing is the same. Treatment of severe mucocutaneous HSV infections. In this case, one should use injectable acyclovir, 5 milligram per kg body weight IV 8 hourly, and children less than 12 years of age and beyond neonatal period, previous slide, period, 10 mg per kg body weight per dose IV 8 hourly for 21 days. So severe mucocutaneous involvement, in which also include the chronic herpetic ulceration, one should use injectable form. In adult, 5 milligram per kg body weight 8 hourly, and the children 10 mg per kg body weight, just double. After lesions begin to regress, one can change injectable onto oral therapy until the healing of the lesions. Next. Generally, we don't see resistance with the acyclovir, but in HIV positive patients, there may be resistance has been reported with acyclovir. In that case, one has to give foscarnet injection. The foscarnet is given when there is resistance to the acyclovir. These are the different dosing schedule of the acyclovir in the herpes simplex virus infection. Neonatal CNS disease is very fatal, so one should be very cautious and one should give the treatment at higher dosage. You can see here 20 milligram per kg per dose IV TDS for 21 days. At least 3 weeks treatment is required. And if there is only neonatal skin, eye or oral disease, 14 days treatment is sufficient. Outside neonatal period, serious involvement 10 mg per kg per dose IV TDS for 14 days. If there is severe gingivitis, 5 to 10 mg per kg per dose IV TDS for 14 days. Acyclovir is very, very safe drug. Acyclovir is one of the safest drug in our clinical practice. Except in some patients, especially in the elderly patient, some patient may have some renal problem, may cause the renal toxicity. Otherwise, this is very, very safe drug. With injectable acyclovir, some patient may develop the phlebitis. Otherwise, acyclovir is very, very safe drug. If there is resistance with the acyclovir, then foscarnet is used, and the dosing is the 40 milligram, usually 40 milligram per kg body weight is given 3 times a day. Here it is mentioned 120 milligram per kg per day, IV in 2 to 3 divided doses till infection resolves. But foscarnet is more renal toxic than the acyclovir. So if you are giving foscarnet, one should monitor the renal toxicity and electrolyte disbalance, especially the calcium and the phosphorus. Next slide. Next viral infection is herpes zoster. Herpes zoster is again a very common viral infection cause involving the skin and mucous membrane. But there are certain conditions when we suspect of HIV and AIDS. Herpes zoster usually involves the single dermatome. But if it involves more than one dermatome, or if there is recurrence, because herpes zoster in non-HIV cases or immunocompetent patients occurs only once in his or her lifetime. There is no recurrence herpes zoster. One time herpes zoster produces lifelong immunity. But if there is a recurrence of herpes zoster, one should always suspect of HIV infection. So if there is a multi-dermatomal involvement, more than one dermatome involvement, and there is a recurrence of herpes zoster, so one should go for the HIV testing. Herpes zoster virus is same as the varicella zoster, varicella virus. It is the varicella zoster virus is the virus which causes varicella as well as herpes zoster. This is also known as the herpes, human herpes virus 3, type 3. It occurs in 5 to 15% cases of the PLSIV. Herpes zoster is very common iris, dermatological iris found in HIV-AIDS patients. So if there is patient is developing the vesicular eruption in localized area with pain, so don't consider it as a drug reactions. The localized multi-group vesicular lesions in a particular dermatome with pain, it is herpes zoster. Course of herpes zoster is also more prolonged with the higher risk of development of post-herpetic neuralgia. The main complication of herpes zoster is the post-herpetic neuralgia, which occurs after healing of the herpes zoster. Clinical manifestation, which I have already told that in this case, patient will have the grouped vesicular lesions in a particular dermatome with severe pain. Generally, first patient will start with the reddish plaque, painful, easy ready plaques, and on that patient will develop the fluid-filled lesions, and which later on may break to form the ulceration. But the distribution will be a single dermatome. In HIV patient, more than one dermatome may be involved. Most common site of the herpes zoster is the trunk. Trunk is the most common site, and then next is the head. The head and trunk are the most common site for involvement of herpes zoster. Next. We can see here multiple grouped vesicles and bullous lesions in the unilateral side, right side of the trunk. You can see here. In most of the time, these lesions never cross the midline. We can see here the multiple group with on erythematous base. You can easily see the erythema on the base. So multiple grouped vesicular या bullous lesion on erythematous base with pain is nothing but herpes zoster. So this is the classical presentation of herpes zoster. You can here you can see the healing lesion of herpes ophthalmicus, herpes zoster ophthalmicus. Herpes zoster ophthalmicus should be treated very carefully because sometimes patient may lose his her vision. So this is the very dangerous condition. One should give. Our approach should be slightly aggressive. If this generally we don't give treatment after 72 hours of herpes zoster, the 72 hours. But if patient is immunocompromised, HIV positive, so one should start treatment even after 7 to 10 days of lesions. So you have to give treatment for this. Higher dose of acyclovir. We'll discuss the treatment later on. Next slide, please. Clinical diagnosis is very distinct. So most of the time, clinical we can diagnose certainly with the on the basis of clinical features. Viral culture, viral fluorescent antigen testing or PCR may be done in the other suspected cases. There is no recommended prophylaxis. There is no recommended prophylaxis. Prophylaxis is not needed. And total treatment duration should be at least for 7 to 10 days. In the treatment, any of these three antiviral drugs can be given. We have the long history, safety history of acyclovir. So we use because acyclovir is easily available even in the periphery. Well, acyclovir may not be available in the all districts or periphery side, but acyclovir will be available. So acyclovir, we prefer acyclovir 800 milligram 5 times a day for 7 to 10 days. Oral route. If patient, because 5 times it is very difficult to sometimes take 5 times a day. In that case, for patient compliance, acyclovir 500 milligram 3 times a day, or valacyclovir 1 gram 3 times a day may be given. Next slide, please. Sorry. Management of herpes zoster ophthalmicus. Late dendritiform lesion of the corneal epithelium should be treated with the systemic or topical herpetic medications. So if there is involvement of herpes zoster ophthalmicus, one should take some opinion from the ophthalmologist also, because there may be corneal ulceration. Cornea is also very commonly involved in the herpes zoster ophthalmicus. Extensive cutaneous lesions have visceral involvement. If there is sometimes herpes zoster may involve the multi-dermatomal involvement, the extensive involvement, or visceral involvement. In that case, acyclovir should be used in the intravenous form, and the dose will be the 10 mg per kg IV every 8 hours until clinical improvement is evident. And if there is improvement, there is no new lesions, initial lesions get starting healing, so you can change over to the oral therapy. Next. Management of varicella in children living with, because varicella is very common in the children age group. Varicella is very commonly found in the children age group. If in moderate to severe disease, acyclovir 10 milligram per kg body weight per dose, IV every 8 hours for 7 days. If disease is very mild, then acyclovir can be given in the oral route, 20 mg per kg body weight orally every 6 hours for 7 days. Next slide, please. Molluscum contagiosum. Molluscum contagiosum is very common viral infection, mainly found in the children. But if it found in the adult and lesions are present on the face and size is more, which we term as a giant molluscum contagiosum. Because in molluscum contagiosum, size of the lesion is usually in few millimeter, 2 to 10 millimeter. But if size more than 15 millimeter or 1.5 centimeter, and lesions are on the face in the adult, then patient is most probably a case of HIV infection. So giant molluscum contagiosum on the face of an adult patient is a case of, most probably will be a case of HIV infection. In molluscum condition, we generally found the pearly lesions, the skin color lesions with central amplification. Central amplification is very, very characteristic finding. Umbilicated, we call it umbilicated. So this is the very characteristic finding. And it tend to proliferate when CD4 count is less than 50 cells per cubic millimeter. Next slide, please. You can see here the multiple patient is adult, lesions are on the face, and size is more than 1.5 centimeter. You can see the size. So if we see this type of lesion on the face, umbilicated, multiple, asymptomatic, no itching, no pain. Umbilicated, you can see here the umbilication, depression in the center. You can see here the depression. You can see here the depression. And size is more than 1.5 centimeter. Then definitely this patient is a case of HIV. Next slide, please. Treatment. Generally, in non-HIV cases, in most of the time, this condition resolves without treatment. That there is no need of giving any treatment of molluscum contagiosum in non-HIV patients. But if patient is HIV positive, there is no any oral drug or topical medicines for molluscum contagiosum. Only treatment of this condition is by destruction. Destruction by any means. Destruction by chemical, destruction by cryo, destruction by laser, electrocautery. So it is only the destruction is the treatment. And most of the time, it responds with the ART. What generally don't respond with the ART, but molluscum condition respond with the ART. Next slide, please. Oral hairy leukoplakia. It is again the very highly indicative for HIV testing because this is very, very rare in non-HIV cases. Oral hairy leukoplakia, as the name suggests, lesions will be found in the oral cavity. Leukoplakia means white plaque will be there. Hairy looks like hairy. The oral hairy leukoplakia, it is caused by Epstein-Barr virus infection. Exclusively found in the people with immunosuppression, especially in HIV positive patients. More than 25% of HIV develop oral hairy leukoplakia at some points. Can occur at any level, but it's more common at CD4 cell count less than 200 cells per microliter. Possibly one of the first sign of development of AIDS. The if you find oral hairy leukoplakia, most probably patient will be case of the HIV/AIDS, and the most common site is the lateral border of the tongue. Next slide, please. Clinical presentation, most common site is the lateral border of the tongue. Initially, patient may have the one-side involvement. Later on, it may involve the both part of the tongue, both margin of the tongue. In this condition, you'll find the white ribbed lesions on the lateral border of the tongue, which cannot be rubbed off. If you try to rub off with the help of the gauge piece, a slide that cannot be rubbed off, this differentiates from the candidiasis because the most close clinical differential diagnosis is oral candidiasis. Next slide, please. You can see here multiple whitish lesions, vertically ribbed whitish lesion on the lateral border of the tongue. This type of lesion may be found in the oral candidiasis. But in oral candidiasis, only lateral border involvement is uncommon. If you want to dislodge these lesions with the help of glass slides or gauge piece, these lesions will not be dislodged. This clinically differentiates from the oral candidiasis. That this is oral hairy leukoplakia. So there is no treatment of oral leukoplakia. It will respond. It will be cured with the ART. Some people have tried because it is basically Epstein-Barr virus, nothing but human herpes virus type 4. Some people have tried the acyclovir high dose, but the result was not found to be good. So at present, no systemic diagnosis is indicated. Next slide. Based on the clinical inspection diagnosis, a scrape test is useful because it cannot be scraped out. Treatment, you will not give any treatment. There is no treatment required. Some people are using tetracycline and apodofloxacin. Or symptomatically, if patient is very concerned about that, the liquid nitrogen cryotherapy may be used, but it is better to leave the lesions. No treatment is required, and the lesions will resolve with the ART. Next slide. After infectious conditions, now we'll discuss about the inflammatory conditions. Next slide. Xerosis and the ichthyosis. Xerosis is nothing but the dryness of the skin. Generally, xerosis and ichthyosis occur in the winter season in our country, especially in the North India. Xerosis and ichthyosis is very common in winter season. But in HIV positive patient, this is very common. Even xerosis and ichthyosis may occur in the rainy season also, or summer season also. So if we call it the secondary xerosis or ichthyosis, if you are seeing the secondary ichthyosis, then one may suspect of HIV. These are also very common in the leprosy also, which xerosis and ichthyosis may present even in non-winter season also, like summer and the rainy season. So if any patient come with xerosis and ichthyosis in rainy season or summer season, we can suspect of HIV infection. Most prominent on the anterior legs, but it may be quite widespread. It may involve the whole body. I think this is the most common inflammatory condition which are found in the HIV/AIDS patient. Treatment is very simple. Xerosis, ichthyosis treatment is only moisturizer. In this condition, you can say or advise the patient don't use soap frequently. If you want to use soap, you can use glycerin soap, a very minimal use of soap, and moisturizer should be applied just after bath and at the bedtime. No any other treatment is required, but sometimes this xerosis may cause xerotic dermatitis. If there is dermatitis or itching, then you can use the mild topical corticosteroids ointment like hydrocortisone ointment. Yeah, fluticasone ointment may be used. So moisturizer and mild topical corticosteroid if there is dermatitis or itch. Next slide. Seborrheic dermatitis. Seborrheic dermatitis is considered to be the earliest cutaneous manifestation of HIV/AIDS. As the name suggests, seborrheic dermatitis involves seborrheic part of the body. Seborrheic area means where we have the maximum number of sebaceous glands. The most common side is the involvement of the whole scalp, eyebrow, nasolabial folds, periocular area, chest area, pubic area, sometimes groin and axilla. So these are the seborrheic sites where we can get the seborrheic dermatitis. It is basically caused by the Pityrosporum orbiculaire and novel, which is also known as the Malassezia furfur. In this, there will be very mild edema along with the fine scale will be there. Greasy scales will be there. The characteristic feature will be mild edema with greasy fine scales on the seborrheic area. Treatment is mild topical steroid and shampoo-based lesion, twice daily application of topical imedazoles like clotrimazole or ketoconazole can be used. Next slide, please. Cutaneous malignancy. We have already told that the Kaposi sarcoma and non-Hodgkin lymphoma, these two are the mainly found in the HIV patient living with HIV/AIDS. So Kaposi sarcoma will be covered in the session of chapter 5. Here we will only discuss non-Hodgkin lymphoma. Next slide, please. Non-Hodgkin lymphoma is the most common malignancy, cutaneous malignancy found in our setup, and prevalence is up to 4.3%, higher than that in the general population. Most kind type of cancer reported in the Indian PLHI. High levels of lactate dehydrogenase and advanced systemic disease in 80% of the cases. So there will be high level of the lactate dehydrogenase. Manifestation depend on the site involved. In this condition, we will find the multiple nodular lesions, asymptomatic nodular lesions under the skin. In HIV, it has a highly invasive behavior due to disease progression, and treatment is the CHOP regimen along with ART. Next slide, please. You can see the cutaneous lesion, very large nodular lesion. These lesions will be asymptomatic, no itching, no pain found in under the skin. Next slide, please. Non-Hodgkin lymphoma is found more in the males, and the prevalence is 38%. In female, it is 16%. Risk is 17 times more, while in female, it is risk is 10 times more than the HIV negative women. Next slide. There are certain miscellaneous conditions which are also very important to know in relation with the HIV. Next. Drug reactions. Drug reactions are very, very important points because cotrimoxazole is very commonly used for various purposes in the ART treatment, in HIV patient treatment, and the cotrimoxazole is the very commonly culprit drug causing the drug reactions. Incidence of drug reaction is just double in comparison to the non-HIV patients. Most commonly, patients develop the maculopapular rash, itchy rash, sometimes vesicular bullous eruptions. But in incidence of severe cutaneous adverse reactions are very, very high in HIV positive patients. Like Stevens-Johnson syndrome, toxic epidermal necrolysis. These two are the very severe type of drug reaction, which are far more common in HIV positive patients than HIV negative patients. Next slide, please. Drug reactions. Most reactions occur in the second week of therapy and are typical maculopapular marfan rash. Use of systemic corticosteroid in treating PCP has substantially reduced the incidence of drug reaction from trimethoxazole. Before systemic corticosteroid use in the PCP, there is very high incidence of drug reaction due to bacterium DS, septan DS. Other drug-induced hypersensitivity reactions like urticarial reaction, exfoliative dermatitis, ectoderma, fixed eruption, edema multiforme, toxic epidermal necrolysis. So severe form of the drug reactions are far more common in the HIV positive patient. If you see the severe type of drug reactions like exfoliative dermatitis, Stevens-Johnson syndrome, toxic epidermal necrolysis, or DRESS syndrome, which is now called the drug-induced hypersensitivity syndrome. In all these cases, one should go for the HIV testing. We have made the rule in our ward and department. If anyone is having the severe type of drug reaction, we always advise HIV testing. Next slide. Puritic papular eruptions are the very common miscellaneous condition which is mainly caused by the mosquito bite in our setup. This condition is mainly found in the developing country, poor country, where there are the problem of the mosquitoes. This condition is very, very uncommon in developed country. This condition is very common condition, and the lesions are mainly found on the extremities, exposed part, legs, and upper and lower limbs, and the face. Covered areas rarely involved. So these lesions don't involve the trunk part because that is covered with the dress. So mainly this area, mainly the exposed part where mosquito can easily be approached is we can find the puritic papular lesions. It's a very severe type of itching, which is very severe, and the most of the patient will have papular lesions, and this papular lesion may get with the secondary infected. Next slide. Prevalence is 11 to 46%. I don't think this is the prevalence of India or worldwide, I don't know, but it is in our setup, it is very, very common. Puritic papular eruptions can be the first marker of HIV infection because most of the times when this condition occurs, CD4 cell counts falls is less than 200 cells. Presents at the chronic bilaterally symmetrical puritic papular style pustules on the trunk is very uncommon side. Extremities and face are the most commonly involved area. Differential diagnosis: follicular, non-follicular puritic eruptions, scabies, insect bite, prurigo nodularis, edematous eruption. Treatment is potent topical corticosteroid, simoleon, or sedative antihistamine is used. And if there is any evidence of secondary infection, then we have to use systemic antibiotic also. Next slide. Acute HIV xanthum and enanthum. Enanthum is the lesion in the oral cavity. This condition is found in the primary HIV disease. We also call it a acute retroviral syndrome. This exanthum occur after 2 to 4 weeks of acquiring HIV infections, and this is which is mainly primary HIV disease. Acute retroviral syndrome is found in those patients who got HIV infection through heterosexual route, and frequency of rise in acute HIV infection can be 50%, about 50%. So this is considered to be the first mucocutaneous manifestation in HIV/AIDS because this occur after 2 to 4 weeks of acquiring HIV infection before the positivity ELISA test positivity. The rash may be maculopapular edematous rash is found. Sometimes petaceous rosea-like lesion may be found, and characteristic it involves the upper part of the body, face, neck, chest, and upper part of the back. Sometimes palms, soles may be involved, but most common site is face, neck, and upper part of the chest and the back. These are the most common sites. These are associated with the systemic features like fever, malaise, myalgia, arthralgia, and pharyngitis. So these are along with the acute HIV exanthum, patient will have involvement of other organs also in primary HIV disease, and sometimes CNS may be involved. Along with this, patient may have the oral edema or superficial erosion on the oral cavity, which is found in 10 to 20% of the cases. Some patients may have the genital ulcer also, and the incidence of genital ulcer in acute HIV exanthum is about 5 to 10%. And this exanthum, along with the other features like GI features and malaise fever, will resolve without any treatment. There is no need of giving any treatment in 1 to 2 weeks. So acute HIV exanthum and enanthum resolves without any treatment in 1 to 2 weeks. So don't give any treatment. But if this exanthum or features of other clinical features of primary HIV disease persist for more than 2 weeks, it means patient will develop AIDS very early. So it may be one of the prognostic point. If it persists for more than 2 weeks, then patient will develop AIDS very early. Next slide, please.
Thank you so much, sir. I'll just check the chat box for the questions. Kiran, meantime, can you please unmute the participants?
Done, ma'am.
Thank you. So there's one question in the chat box. Esophageal herpes, type of virus, simplex or zoster, how to differentiate from osteocandidiasis?
Esophageal herpes, and the only in both the condition, esophageal herpetic infection and esophageal candidiasis, patient will have same symptom like difficulty in swallowing and the pain during the deglutition. In this condition, we have to do endoscopy and take the biopsy. In endoscopy, in the case of esophageal candidiasis, we will find the white deposits with ulceration, while in herpetic esophagitis, we will find only ulceration. So by endoscopy, we can differentiate.
Thank you, sir. There's one more question, sir. What is the treatment of post-zoster neuralgia? Can steroid be given?
Generally, we don't give steroid is not the treatment for the post-herpetic neuralgia. Steroid, one of the indication of steroid is ophthalmic zoster, in acute stage of the ophthalmic zoster. In that case, one can use systemic corticosteroids. For the treatment of post-herpetic neuralgia, steroid is not given. Generally, we classify post-herpetic neuralgia in 2 types. In one type, patient will develop only constant burning, severe pruritus, severe burning without any pain. In that case, we use amitriptyline, 25 mg, OD or BD depending upon the severity. In second type, where there is patient of the severe stabbing pain, in that case, we use the antiepileptic drug, gabapentin, pregabalin, carbamazepine can be used. So for the treatment of post-herpetic neuralgia, amitriptyline group of medicine and antiepileptic groups are given. Systemic steroid is not given. There is no evidence of systemic treatment of the post-herpetic neuralgia.
Thank you, sir. Participants can now unmute themselves and ask questions. They can unmute the mic. Please feel free to write your question in the chat box as well.
Good afternoon, sir.
Good afternoon.
Sir, in our patients, I've seen that piles is a very common occurrence. It's
Piles?
actually not in the hemorrhoids, sir.
Okay.
It's not in the topic covered today, but it's also skin manifestation. So when it is mild, we give cremaphin and Pilex and Lignogen. But when it is severe,
it is better to refer to a general surgeon.
Surgery.
We don't treat hemorrhoids.
Okay.
So I think best person is general surgeons.
Okay, sir. Thank you.
Any more questions? You can unmute your mic.
Excuse me, sir.
Yes, sir.
My question is in post-herpetic neuralgia, if the pain is severe, can we give antidepressants like amitriptyline?
Of course. Amitriptyline, the antidepressant, the treatment.
Okay.
Amitriptyline plus antiepileptic. Most commonly we use pregabalin, gabapentin, even the carbamazepine may be used. Both can be used together.
Okay. Thank you. Thank you.
The PowerPoint presentation and recorded link for this session will be shared via email soon. Any more questions from the participants? Please feel free to unmute your mic.
Don't hesitate to ask question. You can ask any question related.
So I don't think there are any questions. Can we run the post-test now? Piyusha ma'am, you want to ask anything? Yeah.
Ma'am, actually, I wanted to ask about herpetic keratitis and conjunctivitis. Like sometimes we have patient complaining of pain in the eye, and at that time also we have to diagnose. Means we have to take how to diagnose that, sir? Whether it is just plain bacterial or herpetic.
Actually, herpetic keratitis should be diagnosed by an ophthalmologist. Most we don't diagnose without proper examination of the eye. It is very, very difficult to diagnose herpetic keratitis. But if any patient is having ophthalmic zoster and patient complaining of pain, one should suspect, but ophthalmologist should diagnose the herpetic keratitis, because sometimes eye pain is also very common without herpetic keratitis.
Yes.
So ophthalmic examination is very important in that case. So we always try to refer if ophthalmic zoster, patient complaining of pain, we refer the patient to ophthalmic zoster, because we have to give treatment. If patient is HIV positive, we have to give antiviral treatment. There is no any other, along with systemic antiviral treatment, patient may have the total antiviral treatment or herpetic keratitis. Treatment is almost same. So herpetic keratitis, most of the treatment is almost systemic. Same antiviral drug will be effective in treating. But besides other treatment, severity keratitis, ophthalmologist may give some other treatment. I don't have any idea, but it is better to refer to the ophthalmologist if you are suspecting ophthalmic keratitis, herpetic keratitis.
So, and for molluscum, we can do cryotherapy. Usually we don't have that facility. Patients will be asking, or we can give only trichloroacetic cases.
Yeah, you can use trichloroacetic. In molluscum contagiosum, our approach should be very conservative.
Okay.
Don't
Which
try.
is better, sir? Sometimes I given retino A I have given. With it has responded only mild cases. But when we have
Actually-
larger lesions,
Mhm.
that time chemicals are not so.
Actually, in literature, there is no effective treatment for molluscum. It is better not to give any treatment to molluscum contagiosum. It will resolve with ART. Lesions has to resolve with ART
Oh,
and
thank you,
without
thank you.
any scarring. But if patient wants treatment, you can give cryo or TCA. In most of the our OPD, majority of the center don't have the cryotherapy facility.
We don't.
In that case, we can give as a placebo. You can use the trichlorous TCA, phenol applications.
Okay, so thank you so much.
Good afternoon, sir. I had a patient 2 days back. She was 36 years female. She had extensive skin lesion in the abdomen, both the thighs and the bilateral nuclear lesion, and also the back of the thigh. I was thinking that it was a herpes simplex virus, one, and the patient was referred to, even the genital region she had, we referred to a derm. She presented to us after 2 weeks. She had a crusting. Patient had the lesion for 2 weeks. Patient was in the temple. Later on, she presented to us. She's a known HIV and she was on lost follow-up. And we referred to the derm, and she was started thinking that they will start her on acyclovir, but she was started on amoxiclavir, and the swab was taken. What would have been done, sir, right way? She had a crusting that typical that vesicles were all resolved. It was crusted. The lesions were all crusted, and few lesions were ulcerated.
I think this type of lesion is not usually caused by HSV 1 or 2. The most probably patient will be a case of the herpes zoster. In herpes zoster, patient may have the multi-dermatable involvement. In that case, we should use high dose of 800 milligram of acyclovir 5 times a day, along with systemic antibiotic, because second infection is very common in HIV positive patient. So HSV 1 or 2 cannot cause so extensive skin lesions. No. So lesions was only unilateral or bilateral?
Bilateral.
HSV 1 and HSV 2 don't cause so extensive lesions.
Okay.
So most probably case may be a bilateral multi-dermatomal herpes zoster.
I don't know why the derm didn't start on her acyclovir, but because she presented to us late, she came to us after 2 weeks.
Okay, no problem. If patient is HIV
still
positive,
we can start.
Yes, still we can start. But if patient is not HIV positive, don't give. There is no need of acyclovir.
No, she's a positive patient, lost follow-up. She was not on treatment ART. She has lost the follow-up. And then she presented to us with these symptoms after 2 weeks.
Even after 2 weeks, we have to give acyclovir antibiotic treatment in this type of patient.
Fine. Thank you, sir. Thank you.
Excuse me, sir.
Yes.
Sir, we have seen subcutaneous nodules, sir.
Okay.
So I advise biopsy.
Mm-hmm.
And I also give antihelminthics. So what should be the approach for that when you get subcutaneous 1 or 2 nodules, sir? If there are many, we can suspect non-Hodgkin's lymphoma.
So there are so many causes of nodule.
Yes.
First, we have to find out the reasons. Nodule. Even the scabies patient will have nodule on the genitalia and lower abdomen axilla also. So depending upon the etiology.
Not lymphatic nodules. Over the forearm and over the abdomen.
Lipoma is very common condition.
Yes, sir.
Lipoma is very common condition. Even the HIV positive and non-HIV HIV both. Lipoma is very common condition in which we can get the subcutaneous nodule.
Yes, sir.
So there is no treatment of lipoma. There is no medical treatment. It has to be excised. But if there is any other nodule form, first we have to find out the region of the nodule. Then only you can start treatment depending upon the causative agent.
So like I should advise excision biopsy is the right.
Lipoma diagnosis, lipoma is very simple. Asymptomatic,
No.
multiple nodules, cystic nodule, lipoma, multiple nodule which can persist lifelong. You can go for biopsy, no problem. If you are suspecting something else, you can go for biopsy. But lipoma diagnosis is very simple. One is you can diagnose lipoma very easily. We don't at our place we don't advise any investigation.
Okay, thank you.
So we have a question in the chat box. In syphilis
Sure.
management, if VDRL titers remain same after treatment, should we repeat penicillin course?
Actually, if after giving treatment, viral titers should decline. After 3 months, it should decline 4 times. Suppose it is 1:16, then it should be after 3 months, it should be 1:4. But it remains same. And if there is no decline in dilution, or if there is an increase in the dilution, then titer is increase in the titer, then one must suspect of neurosyphilis, because neurosyphilis is very common in HIV patients. In non-HIV patient, neurosyphilis usually occur after 5 to 25 years. But in HIV cases, neurosyphilis may occur within 1 year. So if there is no decline in the titer, then one should go for CSF examinations. If titer is very high, if titer is low, 1:16, if titer is 1:32 or more and not declining after treatment, one should rule out neurosyphilis, because in a sleep patient may not have any symptoms.
Thank you, sir. Piyusha ma'am, do you have any more questions?
No, ma'am. It is not related to skin, but cervical cancer, we have seen so many cases. Diagnosis is becoming very late diagnosis. Early diagnosis, like when I have eye discharge and that time, pap smear is, I don't think it is we have only pap smear, sir, over here. Is it the best one for diagnosis, or cone biopsy is best? Because pap smear, I am feeling that it is not showing the early stage of the disease.
We don't deal with cervical cancer.
Sir?
We don't deal cervical cancer.
Sir, okay.
It is not
Sorry.
part of our presentation. So
Okay.
it is very difficult to comment on that.
Piyusha ma'am, let me check with Dr. Amit sir if he can answer this separately for you. I'll call you in this regards.
Okay,
Any more questions from the participants? Piyusha ma'am, please type your this phone number in the chat box. You can send a direct message to me.
Yes, ma'am. Thank you.
Thank you. So can we quickly run through the post-test now? Singh sir?
Yeah, sure.
Yeah. Kiran sir, can we have the post-test, please? Thank you. The post-test questions are now available on your screen. Please scroll through the questions. There are 4 questions in all. Answer all the 4 questions.
I have to answer? No, no.
No, sir. No, sir. Kiran sir, we can end the e-poll now. Thank you. Answers to the post-test questions. The first question, occurrence of the following skin conditions in PLHIV can indicate CD4 immunological status to be below 200 cells except in psoriasis. Question 2, 29-year-old man living with HIV presents with maculopapular rash predominantly over his palms and soles without any oral, pulmonary or lymphatic involvement. What could be the most probable diagnosis in this case? The answer is secondary syphilis. Question number 3, which of the following is true regarding molluscum contagiosum? Mark all that apply. All the first three answers are correct. It is caused by a DNA pox virus. It spreads through skin to skin contact. Extensive MC is an indicator of low CD4 status, that is less than 50 cells. Question number 4, which of the following statements is not true about skin manifestations in PLHIV? The answer is recommended prophylaxis for varicella zoster is acyclovir 800 mg oral 5 times a day in PLHIV. So this is a statement which is not true about skin manifestations in PLHIV. Kiran sir, can we have the feedback poll, please? Thank you. The feedback questions are now visible on your screen. Please scroll through all the 4 questions and answer them. I thank Puri sir from NACO for the opening remarks. Thank you, Dr. Singh sir, for the facilitating this session and your valuable time.
Thank you. Thank you for that.
The next session will be held on 1st September. That's Thursday. And the topic is non-communicable diseases and mental health, prevention, screening and management among PLHIV. After that, the session will be held on 6th of September. That's a Tuesday. And the topic is HIV and co-infections, hepatitis and leishmaniasis. Thank you to all the participants for patient listening. Kiran sir, we can end the e-poll.
Done, it's all.
Thank you. We shall conclude the session now. Thank you.